Slide 1. Electrophysiology of the Heart is a series of slide tape programs developed and produced by the American Physiological Society. This is Electrocardiography, Applied Theory, Part 2. Content expert, Dr. Morton F. Arnsdorf. 2. This program continues the discussion of concepts developed in Electrocardiography, Applied Theory, Part 1. We will describe some ways in which normal cardiac electrical activity is altered and discuss the interpretation of the resultant changes in the QRS morphology of the electrocardiogram. Remember, this is not a course in clinical electrocardiography, but rather an introduction to concepts useful in the interpretation of the electrocardiogram. 3. Your understanding of the theories presented earlier in this series is prerequisite to successful completion of this program. Electrocardiography Fundamental Theory presented two models for the relationship between the electrical activity of the heart and the magnitude and polarity of potential differences detected at electrode locations on the body. Part 1 considered this relationship in terms of the distributed dipole model and solid angle analysis. Part 2 formulated the single dipole model and the equivalent vector concept. 4. Electrocardiography Applied Theory Part 1 presented a commonly observed normal sequence of cardiac activation and its electrocardiographic record, and analyzed ventricular activation and the QRS complex in terms of equivalent spatial vectors and their projections in the frontal and horizontal reference systems. A simple method for estimating the mean electrical axis was also presented. 5. Questions and answers are provided throughout this program to allow you to assess your readiness for the program, your progress during development of the concepts, and finally, your overall comprehension of the material presented. After a question is stated, you must stop the tape while you formulate your answer. Many of these answers require you to make rough sketches or simple drawings. After an answer is explained, you must stop the tape to assess your response. Of course, you should also stop the tape whenever you want to study the visual material. The prerequisite test begins on the next slide. 6. Given the normal ECG tracing in lead 2 and a series of numbered time intervals, name the cardiac structure depolarized or repolarized during each period. 7. These are the cardiac structures depolarized or repolarized during each period. 8. Given the normal ECG tracing in lead 2 and a series of numbered waves, complexes, segments, and intervals, name each. 9. These are the waves, complexes, segments, and intervals of the normal ECG tracing in lead 2. 10. Given this diagram of the ventricles, with 4 equivalent cardiac spatial vectors in specific spatial orientation and relative magnitudes, make a sketch and label the vectors in sequence, 10, 20, 40, and 60 milliseconds, and briefly describe the activation wavefront movement at each point in time. 11. The small 10 millisecond vector is directed to the right, anterior, and slightly superior, and it represents initial left septal depolarization. At 20 milliseconds, a medium-sized vector directed to the left, anterior, and slightly inferior represents continuing septal and apical depolarization. The large 40 millisecond vector directed to the left, posterior, and inferior results from depolarization of the thick lateral wall of the left ventricle and some continuing septal and right ventricle depolarization. A small 60 millisecond vector directed to the posterior, leftward, and slightly inferior represents depolarization of the thick posterolateral and basal walls of the left ventricle. This is a commonly observed normal sequence of activation. 12. Given the vectorial sequence for ventricular activation in the frontal plane at 10, 20, 40, and 60 milliseconds, sketch the projection of each vector on lead axis 1 and roughly scale the ECG deflection expected in the lead 1 recording. 13. The projections onto lead 1 indicate a small negative deflection at 10 milliseconds and a positive deflection that peaks at 40 milliseconds. Note that the sequence is complete at approximately 80 milliseconds. 14. Given the normal QRS deflections in leads V1 and V6 and their values at 40 milliseconds, sketch the component 40 millisecond vector in each lead and draw the resultant vector in the horizontal reference system. 15. From the negative component vector in V1 and the positive component vector in V6, a large posterior and leftward resultant vector is constructed. 16. In this program, we will describe alterations of normal cardiac electrical activity, asynchrony of activation, and gain or loss in the magnitude of normal electrical forces. Some causes of alterations will be discussed, and the theoretical interpretation of changes in the QRS morphology of the electrocardiogram will be developed. 17. As your first objective, you should be able to describe changes in QRS morphology due to asynchrony of the ventricular activation sequence. 18. The basic principles involved in synchrony and asynchrony of electrical events can be represented in this simple scheme. Two scalar quantities, 1 and 2, representing electrical forces of equal but opposite magnitude, are plotted on a time scale. Clearly, if 1 and 2 occur simultaneously, the equal but oppositely directed electrical potentials will cancel each other and the ECG recording will remain isoelectric. 19. If 1 precedes 2, a small positive deflection, an R wave, will precede a negative deflection, an S wave. If 2 precedes 1, a negative deflection, a Q wave, will precede a positive deflection, an R wave. These examples illustrate the manner in which activation of one area may precede or follow that of another area and unmask electrical events, although there is no change in the magnitude of the electrical events themselves. 20. Asynchrony due to disruption of a normal activation sequence can enhance cancellation and subsequently decrease the magnitude of an ECG recording. For example, if 1 normally precedes 2 in time, the magnitude and duration of the QRS complex will show a typical pattern. However, if the activation sequence is disrupted and 1 is delayed with respect to 2, the magnitude of the voltage deflections will be decreased and their duration will be shortened. 21. The degree of asynchrony influences both the magnitude and the duration of the QRS complex. If 1 normally precedes yet overlaps 2, there is cancellation of the electrical activity in the area of overlap. If 2 is further delayed, however, the asynchrony will unmask and permit full expression of electrical events, increasing both the magnitude and duration of the QRS deflection. 22. Clinically, disruption of conduction pathways will produce asynchrony of normal ventricular depolarization. In the following discussion, we will use right bundle branch block as a model. In common right bundle branch block, the left bundle branch is intact. Therefore, the sequence of septal, apical, and left ventricular depolarization remains essentially normal. 23. The 10 millisecond septal depolarization vector usually retains its normal spatial orientation and its projection onto the horizontal plane appears normal. 24. The 20 millisecond equivalent spatial vector usually appears normal in its spatial orientation and projection onto the horizontal plane. 25. Left ventricular depolarization at 40 milliseconds is normal in the appearance of the spatial and projected vectors. Portions of the right ventricle are being depolarized by this time. At times, the forces arising in the first 40 milliseconds may be anteriorly displayed in right bundle branch block. 26. As the wavefront completes depolarization of the left ventricle between 40 and 60 milliseconds, the spatial and projected vectors are thrown to the right. This is due to the rightward terminal conduction delay, which unmasks the continuing left-to-right septal and right ventricular depolarization. 27. Finally, at 80 milliseconds and beyond, the effects of asynchronous depolarization are most pronounced. Right ventricular depolarization is predominant because it is occurring at a time when it is unopposed by any significant leftward depolarization. The result is that the 80 millisecond and later equivalent vectors are directed anteriorly and to the right. 28. The asynchrony of activation, then, results in the imbalancing of the normal canceling effects of opposing component vectors and in widening of the QRS duration to 120 milliseconds or longer. The RSR prime pattern in V1 and the QRS in V6 are characteristic of right bundle branch block. 29. The asynchrony of electrical events in right bundle branch block is also clearly evident in the vectorial sequence in the frontal plane. 30. Notice that the terminal rightward conduction delay evident after 60 milliseconds in the frontal plane inscription is responsible for the S wave seen in lead 1 and for the widening of the QRS duration to over 120 milliseconds. 31. Right bundle branch block can be quantitatively evaluated by solid angle analysis. Although the individual contributions to each phase of the QRS can be easily visualized, the complexity of the calculations that would be necessary to compute or predict the potential at each point in time is apparent. 32. Given the sequential vectors and completed loop inscribed in the frontal plane for normal ventricular activation and for asynchronous activation due to right bundle branch block, draw a rough sketch of the ECG recording in lead 1 in each sequence. What precordial lead will resemble lead 1? 33. Your sketch of the ECG in terminal rightward conduction delay due to right bundle branch block should show an S wave in lead 1 and widening of the QRS to over 120 milliseconds. V6 will resemble 1 since it is a leftward lead. 34. Given the sequential vectors and completed loop in the horizontal plane for normal ventricular activation and for asynchronous activation due to right bundle branch block, draw a rough sketch of the ECG recorded in lead V1 for each sequence. 35. Your sketch of the ECG in terminal rightward conduction delay should show an R' in V1 and should reflect the widening of the QRS to over 120 milliseconds. 36. Your second objective is to be able to describe the changes in QRS morphology caused by altered magnitudes of electrical forces in the settings of left ventricular hypertrophy and myocardial infarction. 37. Left ventricular hypertrophy an increase in left ventricular muscle mass may involve the septum, the apex, the free left ventricular wall, and the posterobasal segments. Excitation of the larger and thicker muscle mass results in larger and longer-lived activation boundaries, which in turn result in more than the usual preponderance of leftward and posterior electrical forces. This can be expressed in terms of component and resultant vectorial forces. 38. For example, the 10 millisecond septal depolarization vector has this leftward, anterior, and inferior orientation and frontal plane projection. 39. The resultant 20 millisecond spatial vector in left ventricular hypertrophy is also oriented in a leftward, anterior, and inferior direction. 40. Depolarization of the exaggerated left ventricular free wall muscle mass at 40 milliseconds is represented by an extreme leftward, inferior, and posterior spatial vector. 41. Left ventricular enlargement increases the leftward and posterior components of vectors at 60 and 80 milliseconds. The projections of these vectors in the frontal plane have this appearance. Note that ventricular depolarization has not been completed in the normal period of 80 milliseconds. 42. The entire sequence of ventricular activation in left ventricular hypertrophy has this appearance in the frontal and horizontal planes. 43. In this comparison of the normal ventricular activation sequence and the sequence described for left ventricular hypertrophy, the preponderance of leftward and posterior electrical forces is clearly apparent. 44. Notice that during the normal sequence of ventricular activation at this electrical axis, the loop inscribed by the sweep of the spatial vector projected onto the frontal plane appears to proceed in a clockwise direction. At a more leftward or superior axis, the loop may be inscribed in a counterclockwise direction. 45. For example, the spatial loop inscribed during activation in left ventricular hypertrophy appears to proceed in a counterclockwise direction when projected onto the frontal plane. This is due to the early inferior, leftward, anterior orientation of instantaneous vectors and the subsequent preponderance of leftward, posterior electrical forces. 46. Comparison of the ECG deflections in normal and left ventricular hypertrophy activation sequences also clearly reflects the preponderant leftward electrical forces. In this example, lead 1 shows an entirely positive deflection in left ventricular hypertrophy. 47. Left ventricular hypertrophy can also be quantitatively evaluated by solid angle analysis, although, as we have seen, the individual contributions at various instants can be visualized rather easily. Computation of the potentials during the cardiac cycle is complex. 48. Given the sequential vectors and completed inscription in the frontal plane for normal ventricular activation at this mean electrical axis, and for a pattern seen in left ventricular hypertrophy, draw a rough sketch of the ECG recording in lead 1 for each sequence. 49. Your drawing should reflect the change in direction of septal depolarization, the effect of reversal of the loop inscription, and the increased amplitude of the ECG recording. 50. Given the sequential vectors and completed inscription in the horizontal plane for normal ventricular activation and for a pattern seen in left ventricular hypertrophy, draw a rough sketch of the ECG recording in lead V6 for each sequence. 51. Again, your drawing should reflect the entirely leftward inscription, that is, a single R wave, and increased magnitude in the ECG recording. 52. The next situation we will consider is myocardial infarction, in which tissue death and hence loss of electrical force occurs. 53. In this example, the resultant vectors before and after anteroseptal infarction are shown. Loss of electrical activity can be approximated by the so-called infarction vector, which is of equal but opposite magnitude and direction to the electrical activity generated by the muscle before tissue death. 54. The 10 millisecond resultant vector and its projection in the horizontal plane show its posterior and leftward orientation after loss of opposing electrical activity. 55. The 30 millisecond septal and apical vector also reflects loss of anteriorly directed forces and is projected posteriorly in the horizontal plane. 56. Naturally, there are characteristic changes in recorded ECG deflections accompanying the anteroseptal infarction. Note the decreased anterior electrical forces in the inscription after infarction. The QRS complex in lead V1 shows only a QS deflection and may be of greater magnitude than the normal deflection due to the relatively increased posterior forces. 57. Remember that in our discussion of the single equivalent dipole model, we recognized that in order to consider the heart a true single dipole electrical source, electrode recording sites should be at a distance of 5 radii of the heart away from the heart. In solid angle analysis, recording sites in close proximity to the heart are valid, so solid angle analysis may be particularly useful in the quantitative analysis of the ECG recording in the setting of myocardial infarction. 58. This example demonstrates the importance of electrode location. Identical stylized representations of the left ventricular myocardium containing an area of transmural infarction are shown. The electrical events are seen from a precordial electrode and an epicardial electrode. Omega n is the average solid angle subtended by the activation boundary as it moves through the myocardium. Omega I is the portion of boundary removed due to the transmural infarction. Note that the infarcted area might not be detected in a precordial recording of the ECG since omega n is greater than omega I. The infarct would be readily apparent in the epicardial recording since omega I is greater than omega n at this location. 59. The following question and answer use a true posterior myocardial infarction as the basis of unbalanced electrical forces due to a loss of normally occurring electrical activity. Consider the way in which loss of electrical activity in this area would affect the ventricular activation sequence. 60. Given the sequential vectors and the inscribed loops in the horizontal plane for normal ventricular activation and for true posterior myocardial infarction, roughly draw the ECG recording in lead V2 for each sequence. 61. The unbalancing of electrical forces due to loss of the posterior wall contribution will increase the net resultant anteriorly directed vector. This is manifested by the greater positivity in the precordial chest leads, such as V2. 62. We have described several causes of alterations in normal cardiac electrical activity and discussed the interpretation of resultant changes in the QRS morphology of the electrocardiogram. Right bundle branch block was described as an example of an asynchronous cardiac activation. 63. Left ventricular hypertrophy and myocardial infarction were described as examples of gain and loss in the magnitude of normal cardiac electrical forces. The post-test begins on the next slide. 64. Figure A shows a stylized pair of electrical quantities of equal but opposite polarity, in which 1 normally precedes 2. Normal synchrony is depicted in A. Describe the asynchrony depicted in figures B and C. Which sequence would result in the greatest QRS amplitude and which the smallest? Which would result in the longest QRS duration and which the shortest? '65. Figure A shows the normal synchrony of vectors 1 and 2. Figure B shows increased overlap of the vectors, and therefore is an example of cancellation of electrical events, and would both decrease the amplitude of the ECG recording and shorten its duration. Figure C shows decreased overlap of the vectors, and therefore represents asynchronous unmasking of electrical events, resulting in the greater amplitude and longer duration of the ECG recording. 66. Given a set of sequential vectors depicting 1. Septal, 2. Apical, 3. Left ventricular, and 4. Right ventricular activation during common right bundle branch block, sketch and label the ECG deflections expected in leads V1 and V6. '67. Compare your V1 and V6 ECGs with these occurring in right bundle branch block. Note the QRS widening, the characteristic RSR prime pattern in V1, and terminal S in V6. '68. Given two diagrams in the frontal plane showing component and resultant vectors in a normal and a diseased state, in which one of the component vectors is altered, state whether the alteration could result from these causes. 69. The alteration of the component vector in the diseased state could result either from a gain in rightward or loss of leftward electrical force. 70. In this diagram, vector 1 represents electrical activity of a segment of the heart before myocardial infarction, and vector 2 represents the contribution of the rest of the heart. Draw the infarction vector representing loss of electrical activity due to tissue death of the segment responsible for vector 1. Assuming vector 2 does not change, construct the resultant vector for the heart before infarction and after infarction. 71. Loss of vector 1 establishes an infarction vector of equal but opposite magnitude. This causes a dramatic shift in the resultant vector after myocardial infarction. 72. Given the sequential vectors and completed loop inscribed in the frontal plane for normal ventricular activation and following myocardial infarction, state whether the electrical loss occurred in the anterior wall, the posterior wall, the lateral wall, or the inferior wall. 73. The electrical loss occurred in the inferior wall. The loss of inferior forces results in the initial 40 milliseconds of the loop being inscribed superiorly. 74. In the following question, we use mitral stenosis as the basis for unbalancing of electrical forces. Mitral stenosis is the narrowing of the valve between the left atrium and left ventricle. This results in increased left atrial intracavitary pressures, left atrial enlargement, and degradation of conduction between right and left atria. 75. These diagrams show the activation vectors for the right atrium, RA, and the left atrium, LA, in normal activation and in activation with severe mitral stenosis. Draw the P wave ECG deflection in lead V2 in normal activation and in mitral stenosis. Are the alterations of the P wave in mitral stenosis due to altered magnitude of vectors, asynchrony of vectors, or both? 76. The posterior deviation of left atrial forces in mitral stenosis results in a terminal negative P wave inscription in V2. This alteration is due to both altered magnitude and asynchrony of vectors. Mitral stenosis increases left atrial forces and swings the vector posteriorly due to hypertrophy of the left atrium. Also, impaired conduction between the right and left atria causes asynchrony of the atrial vectorial forces, unmasking the left atrial activation. 77. These references are provided as a guide to additional readings and study of the concepts presented in electrocardiography, fundamental theory, and applied theory. 78. 79. 80. This completes the presentation of Electrocardiography Applied Theory, Part 2. The program was produced by the Education Office of the American Physiological Society.